So I'd like to welcome you all to this webinar, which has kindly been supported by Roche. Today, we're going to be exploring the ongoing expansion of subcutaneous anti-cancer therapies. And this is particularly relevant with the expansion of subcutaneous administration of immunotherapy in cancer care. How this is going to work today is that you will have the opportunity to watch a pre-recorded session from myself, my colleague Sara Gomes from Portugal, as well as my UK colleague Jackie Wilson, who, interestingly, she's actually set up a community SACT service previously, so it'll be very interesting to hear from her. At the end of the presentations, we'll switch to a live Q&A session where we'll have our cameras on and look forward to hearing your feedback and questions as well. One final word is to really help us out with our survey that we're conducting across Europe to garner cancer nurses' experience of subcutaneous SACT administration, and the link to that can be found in the chat. So thanks very much, and I'll look forward to seeing you after the session.
Okay. So I'd like to thank everybody for joining us today at this webinar, where myself and some of my colleagues are going to be looking at transforming cancer care, a nurse's guide on the ongoing expansion of subcutaneous anti-cancer therapies. And I'd like to thank Roche for supporting us with this webinar as well. I'm going to hand over to my colleague, Sara Gomes from Portugal, who's going to be talking first.
Thank you, Matt. Hello, everyone. In this webinar, I'm talking about the nurse's perspective on subcutaneous systemic anti-cancer treatment in the academic and in the hospital perspective. So my name, as Matt says, I'm Sara Gomes. And I am a registered oncology nurse specialized in medical and surgical nursing with a master in palliative care. And I'm currently studying for a PhD in nursing. And I'm a lecturer at Nursing School of Coimbra in Portugal. I've worked for the last 15 years at the Portuguese Oncology Institute and for the last 8 years in palliative care unit, and I'm a member of the EONS Education Working Group. So about this team, how is the nurse perspective on subcutaneous systemic anti-cancer treatment, as we said, SACT, academic and this hospital perspective? What we know about this team? In 2020, 27 million people in the European unit were diagnosed with cancer, and another 1.3 million people lost their lives with this disease. So we know that nurses are involved in direct and indirect care of people at risk of and living with and after cancer in diverse contexts. So nurses have a significant influence on the process and the outcomes of cancer care through education, research, policy, practice, and leadership. And all of this offers great opportunities to impact people's health and contribute to the mission of the European Beating Cancer Plan, EU Cancer Mission, and the EONS mission. In 2022, the EONS goes with a framework that they upgraded. It's a cancer nursing education framework. And in the Model 3, we talk about cancer treatment. So what to expect about nursing skills in this team? We know that cancer nurses require knowledge about the principles, mechanisms, and impact of cancer treatments. So it's our job to educate people with cancer and their significant others to monitor for and report signs of acute, chronic, and late toxicities of cancer treatments. It's our job to provide information and support and act as a role model for colleagues who are not in the oncology field, but they have oncology patients to ensure safe practice in the treatment settings. Provide education, it's a goal too, to people with cancer and their treatments, and advice on self-management. We have to empower cancer patients and caregivers, and provide a supportive environment where people with cancer are encouraged to share their concerns and beliefs and to express their preference. And what we are seeing right now, it's there we have a local capacity and capability to deliver the home care regarding to decisions made about patients and caregivers about cancer treatments. So how we can explore that? The SACT concept, the systemic anti-cancer treatment, we know that we have in all of European countries and other international cities, we have the high demand of systemic anti-cancer treatments that continues to rise, the increasing numbers behind the diagnosis with cancer, and high developments in treatment options because of the discovery of new treatments. So the hospitals are in a great pressure on his service, and subsequent patient treatments are delaying. So this could decrease the benefit of the therapy and be detrimental to the patient experience and the quality of life. So when we think about administering subcutaneous CAT compared with the traditional intravenous route, what is the difference? What is the challenges? In this scheme, I can share with you the literature review, how the reference told us how is the advantages and the disadvantages. And we can see it in the two ways, in the patient and the caregiver's way, or in the nursing's difficulties or abilities to do it. So about the patient and the caregivers, the reference told us that self-administered by patients or healthcare providers is something that we can do in the subcutaneous route at home. Being at home in a comfort zone is something that the patients told us that is an advantage. And we know too that sometimes when the patient goes to the hospital to have a treatment, it can go to so much hours of expecting the treatment. And now at home, we can reduce the patient waiting time. We know too that we can offer now a fast infusion because it's a low volume, and with that we can do a time saving. Biography told us too that we can reduce the emotional distress about leaving home, go to hospital, and then return to home. In home, as I said before, it's a comfort zone, so we can manage that. The patients told us there is almost pain-free injection and with a low risk of infusion site infections when we are comparing subcutaneous versus intravenous route. We can empower patient, and we should empower patient in the treatment in own health. At home, we can, and with this route subcutaneous, we can give the flexibility in the anatomical local of infusion. And we know there is a low risk of exposure to the hospital-acquired infections. In the nurses' way, in the studies, we know that this route can save nurses time for other interventions, and they are able to treat more patients. And patients told that, and nurses too, that is one-to-one service. So they are most likely to do it, and they have more motivation to do it and satisfaction. We can reduce in medical and hospital facility fixed costs. For example, the lower cost of resources for preparation the systemic treatment. But it's not all of advantage, so we have a disadvantage too. And the reference told us that the patient and the caregivers have to have the ability of the learning skills. And for those who the patient is not capable, we have to have the presence of a caregiver if they are not capable of doing himself. And for the other hand, we know that we are facing a nurses shortage, for example, in the community. And we have a lot of nursings with a lack of training about this route and about systemic cancer treatments. And we know too that we have geographic asymmetries, like in the human resources, clinical resources, and the consistency of the service provision. So you can see this, I'll reference that are in the last 5 years, but we have research in the last 20 years, more in UK than in other countries of European, but it's something that we want to know more about the future of systemic cancer treatments at home too. So the EONS and Rush are taking this survey with the aim to explore the perspectives of nursing on utilizing new administration technologies to improve the patient care. So I invite you to scan this QR code and to answer this survey to help us better understand how we can support nurses in treating patients. So Matt, I'm taking to you now. Thank you a lot.
Thank you. So my name is Matt Fowler. I'm a nurse consultant for oncology. I work at a comprehensive cancer centre in the East Midlands in the UK. And I'm going to be talking about subcutaneous SACT, but following on from Sara, I'm going to be focusing more on it from a clinical perspective. So I get to wear that lovely red uniform at work every day. I've been a registered nurse since 1997. My fancy job title is that I'm a consultant advanced clinical practitioner for cancer services. And I've worked in oncology and haematology for just over 25 years now. I did spend 3 years as a matron, very much looking at quality from a nursing care perspective, but I soon moved into advanced practice as I really missed the clinical aspect of looking after patients. And I've been in advanced nursing practice now for about 10 years. Outside of work, I enjoy learning Greek and I play tennis regularly. I am doing my doctorate in nursing practice at Duke University in North Carolina, and I'm aiming to complete in 12 months' time. Working in advanced practice, I'm a non-medical prescriber. I do prescribe as well as still administer systemic anti-cancer therapy and also authorise blood products as well. I'm an honorary lecturer at Bethlehem University, and I am an active EONS board member and the treasurer for the European Oncology Nursing Society as well. So when we think about subcutaneous SACT, where did it all begin? And it actually began back in the 1960s with the use of L-asparaginase, which we still use now for acute lymphoblastic leukemia. Moving on, we then started using cytarabine, otherwise known as Ara-C, and bleomycin. And then not much happened then up until the late 1980s when we started using luteinizing hormone-releasing hormone agonists for prostate cancer, and we also have used them. We use them for breast cancer as well. And then from 2004 onwards, it's just exploded. And you can see from the list of drugs here, predominantly in the haematology setting with the use of azacitidine, bortezomib, daratumumab, alemtuzumab, rituximab, which have all revolutionized cancer care for haematology patients. And obviously with trastuzumab then coming on board for HER2 positive breast cancers, and latterly pertuzumab, trastuzumab, and obviously more recently, and a very exciting development with the use of atezolizumab. So we are actually administering immunotherapy subcutaneous now as well. So this has obviously been a bit of a game changer for us as well. So what are some of the challenges that we face when we administer subcutaneous SACT? And for me, one of the biggest challenges is preconceptions that often people will assume that because we're administering a subcutaneous treatment, that it's not going to be as effective or as potent as when we give intravenous therapies. And I think it really does command respect. We need to handle it and treat it exactly the same way that we do intravenous and oral SACT. skin reactions can be quite common and quite challenging. And in particular, for those of you that are familiar with administering azacitidine, we can see some really quite severe skin reactions that can take quite a long time to dissipate. And equally, when you've got patients that are receiving multiple cycles of azacitidine, then they can get some really severe reactions on their abdomen. Now, nurses, I think sometimes we can be a bit of a barrier to subcutaneous SACT treatments. And I think we just need to make sure that when we do talk through with our patients about having subcutaneous treatments, that we do talk about, you know, education is key, and that we are advising our patients that they can get skin reactions, they can still get all of the systemic toxicities that our patients receiving intravenous therapies receive. So I think it's really important as a group of nurses that we make sure we're well educated and informed. I think it's really important that we talk about privacy and dignity, because often if we think about a lot of these subcutaneous treatments, they're administered in the abdomen or the thigh. Traditionally, chemotherapy day units aren't that well set up from a privacy and dignity perspective. So I think it's really important we think about where we administer this treatment, as in location-wise, that the patient's privacy and dignity is maintained at all times, and making sure that we're culturally sensitive as well. So thinking about the site of administration, that does link in with the privacy and dignity aspect. And I think moving forward, I think, you know, for companies that are developing subcutaneous treatments need to think about that, not just about, well, we prefer it to be administered in the abdomen or the thigh. Are there other sites that could be considered for administering subcutaneous treatments that don't necessarily involve the patient exposing themselves as much? We have to think about the daily visits that some of these treatments require, particularly from a hematology perspective. If you've got patients having daily azacitidine for 7 days, or cytarabine for sometimes longer periods, which is why the more newer treatments, such as when we're thinking about administering immunotherapy subcutaneously, it doesn't require those daily visits. We still have to think about the nurse's exposure to SACT. It is no different to when we're giving intravenous therapies. And if anything, when we do administer subcutaneous SACT, there is the potential for some more exposure, because we don't have those closed systems yet that we do have with intravenous treatments. Volume has to be considered. If we think about some of the treatments that can require up to 15 mils of drug to actually be inserted into the patient subcutaneously, that does need to be done slowly. And equally, we need to think about whether or not drugs such as hyaluronidase are used so that we increase the absorption. And I think one of the biggest challenges we have, and particularly when we think about immunotherapies, when we think about combination therapies, where you might have a patient receiving an immunotherapy agent with a tyrosine kinase inhibitor, they then present with loose stool. Could that be immunotherapy-induced colitis? Could it be diarrhea secondary to the tyrosine kinase inhibitor? And equally, when we're thinking about subcutaneous SACT treatments that are administered alongside an intravenous treatment, you've equally got to think about the patient having 2 needles, one for the cannula and then another one for the subcutaneous treatment as well. So these are all just some issues that I feel we do need to consider. So what are the opportunities of subcutaneous SACT services? We're going to be hearing from our colleague Jackie Wilson, who set up a community service previously in the UK. But see, these are some of the things that I think we need to think about if we're looking at community services for subcutaneous SACT treatments, and that's temperature control of the drugs that we administer. Does it need to be refrigerated? How do we ensure that we maintain that close temperature control with cool bags, or does it need to be kept at room temperature? Is the patient going to be storing the medication at their own home? Controversially, I would ask the question, does all of this need to be administered by SACT trained registered nurses? Because immunotherapies, other cytotoxic drugs are administered by non-SACT trained registered nurses in the hospital setting. And equally in the community in the UK, we use our generic district nurses for often administering for administering cytarabine, and equally for disconnecting 5FU pumps in patients' homes. There's cost that needs to be considered. You've got one nurse going out to somebody's house, whereas on a traditional chemotherapy day unit, you've got multiple nurses looking after multiple patients. We often make assumptions that all cancer patients would like to have their treatment in the home. That's not necessarily so. Not every cancer patient will want to turn their living room into an extension of a day unit. And I think that does need to be taken into account. They may wish to keep their home as their home and not for having their cancer treatment in. And equally, we have to think about the safety of the registered nurse. They're going to be a lone worker going out to these patients' homes. So this does need to be taken into account. I think one area we do need to look into more is patients self-administering their own chemotherapy when it's subcutaneous. And I will provide some links at the end of this talk so that people can look into that, because it is happening. And I think we need to empower patients to do this as well, if they're able to do so. By looking at different ways of working, particularly in the community, we increase capacity in our already busy, overstretched day units in the cancer centres. And equally, I think we need to look at, co-location of work in primary care. So we can look at specific primary care centres that you could have a number of patients that are coming to get their treatment by trained oncology nurses and haematology nurses. And I think the future lies in on-body injectors, where the patient can simply apply an on-body injector, like I've got that example there of Neulasta, so growth factor, that patients can actually just apply the on-body injector and administer their own treatments, whether that be in the hospital setting or, for me, preferably in the home setting. And I think equally, more pharma companies need to be looking at subcutaneous therapies up front. We often develop these intravenously primarily and then move on to subcutaneous therapies further down the line. I think it'd be really interesting if we start developing therapies, particularly immunotherapy, that patients can have subcutaneously, as opposed to always going for the traditional intravenous route. So I would like to thank you all for joining us on this webinar today, and equally for listening to me as well. I have got some really interesting links here to patients self-administering subcutaneous treatments, and I've equally got a video that can be watched as well about launching a self-administration service as well. So thank you very much. Hi, I'd like to introduce my colleague Jackie Wilson now, who is a clinical nurse specialist for haematology at Warwick, and I'm very lucky to have worked with Jackie for a number of years now throughout our careers. So thank you for joining us today, Jackie.
Thank you for having me.
What I wanted to ask you today is, I'm fascinated by the service that you set up in Birmingham regarding subcutaneous systemic anti-cancer therapy service for haematology patients. And I wondered if you could just tell us a little bit about that service that you set up.
So at the time I was a day unit manager for our very, very busy haematology and oncology day unit, and we were really struggling with our capacity. Many patients coming through, and some of our patients that were having our subcut treatments were suffering really long delays, and it was becoming a real problem. So one of our haematology consultants, we applied for some funding through a charity called K Kendall Charity, and this was a system that we knew of from the QE hospital, actually, that had already got a similar program up and running. And I was seconded out of my day unit manager role to set up and trial essentially a system for delivering subcut chemotherapy in the community. So I was on my own initially, and it was to work up. So I had to liaise with the senior management team, get the consultants on board. I had to go through medicines management for single nurse checking, and basically, and pharmacy as well, to get them involved for delivery of the chemotherapy. And patients, we basically, should start with that. We did a patient satisfaction survey initially. That was my first job to see whether the patients actually wanted this and whether they thought it would make a difference. And overwhelmingly, they said that it would. It was something that I was getting calls about actually as soon as I started asking the questions. I was getting calls from patients asking when I was going to start, because it was really felt that this would make a positive impact to their treatment experience. So once I'd collected all that data and presented that, it was felt that it was definitely worthwhile and going forward. So did all the necessary checks and safety checks with lone working and all those sorts of things. And we trialled initially started with an azacitidine patient, so treatment every day for 7 days, just one patient. That went really well and just slowly sort of built up. After 6 months, I was able to prove that the service worked. So I was able to recruit a colleague, a Band 6 colleague, and we just took it from there, really. And I think it's still running, but it's come with its challenges, which we'll talk about in a bit. But it was very rewarding service.
So what would you say the highlights are of setting up such a service?
The patients, the impact it had for them. I still remember as a day unit manager having 5 gentlemen sitting outside the day unit waiting for their subcut azacitidine, having waited there for a while. And, you know, we tried our best to avoid that, but sometimes we couldn't. And actually talking to them afterwards, we did a 6-month post-satisfaction survey for the patients that we took onto the service, and it was really it really came out what their experience had been. Obviously I knew before, but the change that it had made for them, you know, they felt, even though we thought we were doing the right thing by when we did get to them and bringing them in quickly, giving them their injection and sending them on their way, because we thought you've been waiting ages, it actually had a really negative impact on them and their mental health, because they'd sat there for hours. We brought them in, did their injection and sent them away, and actually they wanted that contact. They wanted to be able to speak to us and talk about things, and going out to them in their own environment, being able to do that treatment, having that chance to talk to them and go through, you know, meet them, talk to them properly, find out what was bothering them. They felt much more empowered. They were seeing one nurse or two nurses, one of two nurses. They were seeing the same consultant, because we had a consultant clinic in the community as well. So they were able to see the same consultant. They weren't having to come to hospital every day. The wait times for the car park, the cut charges, all those sorts of things, and just seeing the benefit for them actually was beneficial for me, because I got much more job satisfaction out of seeing the benefit that it had for them.
So you spoke about lots of positives there. Are there any key lessons, shall we say, that you learned that maybe you would have done differently or possibly reflected upon when you were setting up the service?
I think I think we could have expanded a lot more quickly, actually, and gone with the momentum of the service to try and build it and increase it more quickly. It didn't help that I left to go on maternity leave, sort of just as things were taking off. But I think we could have maybe looked and sort of built on the momentum of the service to try and expand it and get it more substantial. But it was challenging. It was getting funding. We were charity funded for the first 2 years, and then it was getting the trust to take that on. And you need more staff. 2 nurses can only do so much work. And although it's seen as a really positive thing for patients financially, it's challenging. And I've seen that coming into my new role, where I have tried to set up a similar service. That is the challenge. Also sort of I tried to do this as much as possible, but keeping that momentum with pharmacy and the senior management team to kind of keep things going. I think, really just building on the momentum and trying to sort of keep the service building was probably the problem. But I did leave after to have my child. So when I came back, it kind of, and then COVID hit, which was obviously the biggest challenge. Although having that service in COVID was really beneficial because we were able to support our patients, and obviously those patients still managed to get their treatment because we were able to keep it going during COVID. So that was good.
So what advice would you give to any registered nurse out there who's thinking of setting up such a service?
I think I've learned quite a bit actually from trying to do that here. So I think getting patient voices are the strongest. It's the patients that will push this forward. So that's the first step, is to ask the patients what they want. Where do they want to receive their treatment? What do they like about coming to the day unit? You know, if they're happy at the day unit, it's difficult for them to picture having treatment outside, but it's about educating them about ways that we could change their treatment that would hopefully make it better for them. Speaking to your senior colleagues, getting the consultants on board. But really it's starting with the patient voice, getting the patient questionnaires out there, speaking to the patients and going from them, because they're the lead in this. And if they're the voices that saying they want it, then everything else will hopefully follow. So pharmacy as well, we're getting them on board, and whether they can support you with delivering the treatment, because that was probably one of the biggest challenges I had as well.
So the last question I'd really like to ask you is, we're obviously looking at expanding subcutaneous treatments now into the field of immunotherapy. Can you see any challenges to us starting to administer, now that we're starting to administer immunotherapy subcutaneously? Can you see any challenges to that?
I think it's mainly staffing and what your support network is. I think that's probably one of the biggest challenges, because you have to start sort of small. But I know some centres are doing immunotherapy in the community, so obviously it can be done. But I think, and if it's subcut, then hopefully that will be better. But it's nurse, I would say, pharmacy being able to dispense the medication and the nurse time it's going to take to do that. Whether you do that in patient homes, or whether you do that in a community centre like a GP or an ambulatory bus or something like that, might be better to treat more patients. I think that was probably our biggest challenge, is we were so small, we only had 2 members of staff, and just the time it takes that nurse to go and deliver that treatment and maybe monitor the patient afterwards, whether it would be better in like a primary care setting, or a hub where you are able to have a couple of members of staff treating more patients and have that kind of clinical support. I'd say that's probably the biggest challenge, really. Okay. But actually delivering in patient homes is a positive. You've got 999 if you need it, but it, if patients want it. But sometimes they don't want their treatment at home. Sometimes they want to come to the day unit because they don't want to think they're having cancer care in their own home. I would say probably those are the biggest challenges.
Okay. It's been an honour to talk to you today, and you've been really, really helpful. So I just wanted to say thank you, and I'll let you get back to your busy job.
Okay. Thank you very much. Right. Thank you for having me. Thank you.
Bye-bye.
Bye.
Thanks to everybody for joining in and watching that. We'd like to open it up now to a Q&A session if anybody's got any questions for us. And that goes for myself, Sarah or Jackie.
Hi, everyone. I think this theme, this subject that we are talking here in the webinar, it's something that we have a few practice in the present, but I think it's something that we have to talk now and to develop some networking for the future. As Jackie said, some of us want to be at home, but some of others want to be at the hospital. So I think if we think in patient-centered care, we should give the options, and then so should be, we should have a networking and the capability to deliver what the patient wants. So this is a challenge in European now.
Can't see any questions coming in so far. So I've got a question for you, Sarah. So how do you think nurses can best educate patients on immunotherapy toxicities and when to contact their healthcare provider?
Mm-hmm. Yeah, this is an interesting topic. In our experience, there is a few experience in the Portuguese healthcare system. We have to the patient, or if the patient is not capable, we have to have a caregiver that can manage that side effects that occur in the home care. But we, the healthcare system and nurses, has to fulfill some how do you say it? Some guidelines, some security luggage to can deliver this treatment at home and can manage these toxicities. It's not easy with the human resources, the clinical resources that we need to have. I think this is when you think to bring hospital to home. I think the most challenging is this. In hospital, the patient came to us, and you have everything to give to him with all the security that we all in the multidisciplinary team, we thought about it, and we built this structure to give them the most security treatment and to manage the toxicities. But at home, we have to construct, to build this. I think we have to select patients because not everyone have the security at home to do this, to manage toxicities, to have a phone call with available 24 hours if something happens, to have the at home the circumstance and there are some patients that don't have water, that have minor conditions at home. So I think not everyone is eligible to do it at home.
Okay, thank you. We've had some questions come in. So let me have a look. I can see from my colleague Bilal, he's saying systemic anti-cancer treatment at the end of life might do more harm than good. I could not agree more. And I think we need to be very careful about selecting our patients for treatment. We've got a question here. What would be the most effective method to train nurses for administering subcutaneous SACT? So I can only talk about it from a UK perspective, but this is something that I've used in Palestine when I've been teaching out there as well, is that we have the EONS SACT passport, and it's an easily accessible document. It is a really, really good document that could be used. But for me, it's about going with your own local training competency documents, and that you are deemed competent by another registered nurse who is competent in administering systemic anti-cancer treatment subcutaneously. But if anybody's struggling to come up with a competency document, that is a really useful document to use, and I suggest it all the time.
And we have in the chat here, someone says that in a large community may be difficult. Yes, the geographic challenges to bring home these cares. And of course, it's one of the things that we have to thought about it, and we have. That's why I said before, we have to select patients. We have to trial to check the available the knowledge, the capable of literacy of the family, of the networking of the community nurses. It's a lot of things that we have to deal, and we have to prepare for everything going correctly as we want.
Any more questions from anybody at all? No? So I think we should probably think about letting everybody get back to their work. I've certainly got a few patients still that I need to see in clinic. Just to say, we really would appreciate your support in filling in the survey. It will help us out because we're trying to get as big a picture as possible from across Europe into nurses' experience of subcutaneous treatments. And this is going to be the first of a series of webinars that we're going to be doing. So it's been really nice to see you all today, and I look forward to seeing you again soon.